Hi, Mrs. Payne, it's Stacy. I'm going to be your student nurse today. The doctor has ordered a nasogastric tube to be inserted, and we call that an NG tube for short. So it's a tube that goes from your nostril all the way down to your stomach. So for this situation, it looks like you were admitted with a small bowel obstruction, and so the doctor wants to decompress or shrink your stomach up by having you connected to intermittent suction, and it should relieve some of your pain. I noticed that you were ordered to be NPO, so we're going to slightly adjust how we do this insertion. I can't give you any sips of water because it's not allowed, but I will be asking you to swallow intermittently and change the position of your head. This shouldn't hurt, but it will be a little uncomfortable. You might gag a couple times, but as soon as I have found the correct route, we are going to be very quick on inserting this tube, okay? This is a clean procedure. So the supplies that I have gathered for this is I have my Salem sump. This is a 12 French, it's a very small tube for you. I have some lubricant to kind of help that slide in. I've got tape to help hold it in position and help me mark where I need to go. I've got a safety pin, and then I have an irrigation kit so I can check the output of what is in place. And then our hospital actually has the pH strips. It's rare, and we're going to confirm with x-ray to make sure everything is in correct position. I'm going to sit you up just a little bit more just because it'll help me raise you up, and I'm going to get everything set up for this. So I'm going to open my supplies. My lubricant. It's like opening a ketchup package. You can never find where you actually are supposed to tear. Get the lubricant. Okay, I'm gonna get a couple pieces of tape here. So one of these is going to be a temporary piece of tape that's going to hold the tube in place while we're waiting for x-ray. And this next one is going to help me mark once I measure where we're going to go for insertion. Okay. So I am going to need to save this little piece that helps me connect to suction later, but right now I just need it for the syringe to help me pull back. So we're going to start off with measuring. So the rule of thumb is I'm going to measure from the tip of the patient's nose to their ear loop down to their xiphoid process. And then we're supposed to add 10 centimeters. I have found if you go from the tip of the nose around their ear down to the xiphoid process, it ends up being the same distance than adding that 10 centimeters. So I just go around the ear. And then instead of marking with a permanent marker, I put a piece of tape, and this lets me know when I've met where I measured, instead of having a bunch of markings on my NG tube of where I'm trying to get to. Now, with our mannequin, I'm never going to make it to this spot because I've got equipment in their chest that makes them a little more shallow. They don't, in fact, have a stomach. So this is an unrealistic marking, but on your real patient, you should be able to get to the spot that you measured to the end of their nostril, okay? I also find that it's easier if you connect your syringe now, because your dexterity is not so great when you're new at putting these NG tubes in, and to also keep the top of your NG tube above your patient's stomach, so that way once you've reached the stomach, you don't have any backflow coming down and underneath your patient. I'm going to lubricate 2 to 3 inches of the tube to help it glide in. Now, Mr. Payne, or Mrs. Payne, have you had any trauma to any of your nostrils, broke your nose? You have not. Have you had a nose job? You have not. Okay, so we're gonna check to see which nostril is best for you. So I'm gonna occlude your nostril. I need you to blow out. Okay, and blow out again. Okay, breathe in. And breathe in. So it sounds like this nostril over here is a little bit stronger. You might have a little bit of a deviated septum. Everyone's got one nostril that's better than the other. So we're gonna go in with this nostril. Okay, so what I need you to do is I just need your head to be back right now. When you feel me reach the back of your throat, you're gonna actually bring your head forward, okay? And I need you in a swallowing motion once you bring your head forward, okay? All right, here we go. 1, 2, 3. Yes, very irritable, okay? Yes, it's in the back of your throat. Bring your chin forward, okay? And we're moving. You're doing a great job. I don't see any distress. The patient is not coughing, so we have not reached the lungs. I'm doing a twisting motion to try to get it to advance. And for the mannequin, this is roughly where we can usually get. It will give you some resistance that you cannot get any further. On the real patient, I still needed to go to that marking. So I have met resistance. Okay, so Miss Payne, you did great. Everything's good. I'm gonna put my temporary piece of tape on your cheek right here. I'm going to aspirate. I should see yellow, green, possibly brown, depending on what they're admitted for. Secretions, if I have my pH strips at this point in time, I can then measure the pH of the output by just putting a little of the fluid on the pH strip, looking to see if it's basic or acidic to tell me if we are in the correct location in the stomach. I'm going to observe it. If this looks like gastric contents, I'm actually going to give this back to the patient because this is their own gastric secretions. I'm going to disconnect my syringe and I'm going to put my connector for suction on there right now, and we're going to call for X-ray at this point in time to confirm placement. So X-ray will come, they'll do a KUB. So X-ray board will go under their stomach. They're looking for that you've made it into the stomach. Once that has been confirmed, we can move our temporary tape. So it looks like everything was great, Mrs. Payne. I'm just gonna put a little bit more permanent tape. There's probably a device at most of the hospitals for your NG tubes. So a little adhesive barrier cream on their nose before you do this. I like the split tape. You're just gonna wrap under on one direction, and you wanna be as tight around this tube as possible so it doesn't wanna move, and as close to the nostril as possible, but you do not wanna occlude their other nostril. And then the other one comes around the other side. And then if you're good and tight, you're gonna hold at their nose, give that a little tug. That tube doesn't wanna move. And that reinforces, if this was, we made it to the patient's real stomach, there would be extra tape down here. I can now take that one off, and where this ending is reinforces where we're trying to go. I do wanna note what is the most recent or closest number to the insertion to relay that to my fellow coworkers. So if they come in and the tube looked like it moved, and we see a more shallow number at the nostril, we know the tube has come out. If we see it a little deeper, it just means it's coiling more in the stomach. So when you're coming to assess your tube, you really do want to note the number of where it's at. Some places will actually measure the distance of the tube that is outside of the patient. I firmly believe if you just communicate the number at insertion, that's the best thing you can do. For intermittent suction, we're going to get our suction tubing. We're gonna go upwards for suction to intermittent, and we wanna do low intermittent. So what we're gonna do is we're actually gonna turn the suction on. We wanna stay in the green zone, so it should not go above 80 millimeters of mercury. So you're just gonna play with your dial until it only reaches 80, no further. So you're just occluding the suction with your thumb. Once it has done that, you can now connect this to the patient. And what we're going to do is we don't want this to get pulled. So I'm gonna ask Mrs. Payne if you could turn your head away from me. So her neck does not really move. You're creating the slack, and I just put a piece of tape with the slack, and I'm gonna pin this to her gown. And then that way, it will not accidentally get pulled out. I will say you need to also make sure that their gowns are then tied behind them, because if their gowns slip down, that's going to also pull at their tube. So she should be able to talk to you. She shouldn't be coughing. That would be signs that the tube is actually in the lungs. We have some slack. We are above the stomach. We should start having that same color of secretions that we pulled out with our syringe now in the collection chamber. Patient, you just clean anything up, wipe away any of the extra lubricant that might be around their nostrils. And Mrs. Payne, you did a wonderful job. You didn't cough too much. I know it's a little uncomfortable, but your stomach should start feeling so much better now, because it's going to be shrunk down, a little less pain coming at you. I'll come back in. We can moisten your mouth. We can do any throat spray for you. Anything that might be experiencing some pain, we'll try to take care of that for you, okay? All right, thank you, Mrs. Payne. I'll be back in to reassess and check position for you. Thank you so much.